Welcome to this Masterclass Explainer, where we are decoding the brand new CPT 2026 dedicated framework for telemedicine. The whole landscape of digital care coding has shifted, guys. We are finally getting a dedicated, structured block of codes just for virtual patient encounters. So, if you've been relying on that old patchwork of temporary guidelines, and let's be real, it's been a massive headache for all of us in medical coding, it's time to clear your mental hard drive. Today, we're mastering the definitive CPT 2026 rules. Let's take a quick look at the syllabus for today's blueprint. We'll start with the CPT 2026 telemedicine framework, then move into audio-video telemedicine visits, followed by audio-only patient encounters. After that, we'll hit virtual check-in guidelines and wrap things up with edge cases and modifiers. All right, jumping right into Section 1, the CPT 2026 telemedicine framework, focusing on the new 98000 to 98016 block. So, this brand new code block, spanning from 98000 to 98016, is basically your new home base for all things virtual care. The absolutely crucial point you need to remember is that every single code from 98000 to 98015 hinges entirely on the concept of real-time, live interaction. The word synchronous is doing a lot of heavy lifting here. We're not talking about sending an email and getting a reply a day later. No, this is about a live, interactive, back-and-forth dialogue between the provider and the patient, whether that camera happens to be on or off. Moving on to Section 2, audio-video telemedicine visits, and visualizing those thresholds. Now, this right here is the gold standard for telehealth, both visual and verbal communication happening live. Take a look at how cleanly the 2026 guidelines scale the medical decision-making, or MDM, and the time thresholds for new patients on video. It is a perfect stepped progression. For a new patient with straightforward medical decision-making, you use code 98000, which has a 15-minute time threshold. From there, it scales up beautifully in exact 15-minute increments. Low complexity, that gets you to 30 minutes with 98001. Moderate takes you to 45 minutes with 98002. And high complexity maxes out at a 60-minute threshold for code 98003. It's incredibly logical, right? But, and this is a big but, when you're using total time on the date of the encounter for your code selection, these specific minute marks must be met or exceeded. There's absolutely no rounding up here. If your documentation says 29 minutes for a new patient, well, you have not met the 30-minute threshold for 98001. You must meticulously document the total time spent to support your code selection. Accuracy is everything. Now, let's contrast that with established patients. Notice how the time thresholds are lower? That directly reflects the existing relationship with the provider. For an established patient, straightforward MDM under code 9804 starts at just 10 minutes. Then it steps up in 10-minute intervals. 20 minutes for low complexity, 30 for moderate, and 40 for high complexity with code 9807. The logic here makes total clinical sense. The provider already knows the patient's baseline history, so naturally, less time is required to reach that same level of medical decision-making. All right, let's roll right into Section 3, audio-only patient encounters, focusing on phone-based care. We all know how it goes. Sometimes the tech just fails, or a patient simply doesn't have the internet bandwidth for a video call. Well, the 2026 guidelines built out a specific pathway just for this. Keep this rule in your back pocket. For codes 98008 through 98015, exceeding 10 minutes of medical discussion is a strict, non-negotiable baseline. Seriously, this is exactly where auditors are going to look first. If your audio-only visit is 9 minutes long, you cannot use these evaluation and management codes. You must cross that 10-minute threshold of actual, interactive medical discussion. And this beautifully illustrates how the audio-only blocks directly mirror the audio-video hierarchies we just looked at. If you can memorize the video codes, you essentially already know the audio-only structure. The new patient audio-only codes 98008 to 98011 share those exact same 15, 30, 45, and 60-minute thresholds. And the established patient audio-only codes 98012 to 98015 share the 10, 20, 30, and 40-minute thresholds. Literally, the only difference is the modality. The camera is off. The clinical complexity and the time requirements, exactly identical. On to Section 4 now, virtual check-in guidelines, specifically code 98016. So this pillar steps away from those full visits and addresses the brief triage encounter. Code 98016 is specifically designed for established patients who initiate a quick 5 to 10 minute check-in just to see if a bigger appointment is actually necessary. Now, the key word here is patient-initiated. A doctor cannot just cold call a patient to check up on them and then bill this code. No way. The patient has to reach out with a concern, and then the provider jumps on a quick audio call, and remember, video is not required here, just to evaluate whether they need to come into the office or schedule a full telehealth visit. It's triage, pure and simple.
But here is where you really need to pay close attention to the timeline. This code is strictly invalid if it falls too close to related prior or subsequent visits. If this quick check-in relates to a visit the patient had in the past 7 days, it's considered bundled into that previous visit. You can't bill for it. On the flip side, if the check-in results in you telling the patient, hey, you need to be seen right away, and it leads to an EM service within the next 24 hours or the soonest available appointment, then this time just gets bundled into that upcoming visit. It only stands on its own if it sits cleanly outside of those specific timeframes.
Finally, Section 5, Edge Cases and Modifiers. Let's master the nuances. Knowing the theory is great, but everyday medical practice throws a lot of curveballs, and thankfully the 2026 guidelines give us specific rules for how to handle them. For instance, imagine you're deep into a video visit. Everything is going great and suddenly, boom, the Wi-Fi completely drops. How do you code that? Do you bill it as video? Do you scrap the whole thing and bill it as audio? This is probably the single most common technical glitch in telehealth, and now we finally have a definitive answer. The new CPT guidelines clearly specify that you bill based on whatever modality took up the majority of the time, provided you still meet that 10-minute minimum for audio only. So let's say you did 20 minutes on video, the screen froze, and you had to finish up with 5 minutes on a phone call. You bill the audio-video code because video was the majority. However, if you did 5 minutes on video, it crashed, and you spent the next 15 minutes on the phone, you transition to the audio-only code. But do not forget that golden rule. To bill the audio-only code, your total medical discussion must still exceed 10 minutes. Next up, you absolutely must accurately reflect where the patient is physically located during the telemedicine encounter by using the correct place of service, or POS code. This directly impacts your reimbursement. POS 10 has basically become the default for most payers when the patient is just sitting at home in their living room. POS 02, on the other hand, is reserved for when the patient is in a clinical setting, like say they went to a rural clinic but they're teleconferencing with a specialist at a major hospital. Getting this right is completely foundational to a clean claim. And this side-by-side comparison perfectly highlights how your modifiers have to align with whether the camera was on or off. Modifier 95 basically tells the payer, hey, we could see and hear each other perfectly in real time. Modifier 93 is your signal that you are operating completely audio only. Trust me, mismatching your CPT code modality with the wrong modifier is a guaranteed fast-track way to trigger an audit or a denial. Okay, before we wrap up, I want to give you a critical warning regarding time-based evaluation and management. You cannot double dip. You cannot report telemedicine alongside an in-person E&M service on the exact same calendar date. If you see a patient in the clinic in the morning and then do a telehealth follow-up with them that same evening, the times and the elements of those services must be summed up and reported in aggregate as a single in-person service on that specific calendar date. Mastering these new 98,000 series codes is absolutely going to protect your revenue and ensure your clinical documentation is flawless as we dive deeper into the future of virtual care. But, as telehealth technology rapidly evolves into AI and remote monitoring, you've got to wonder, will these 2026 guidelines be enough to keep up? Or are we literally just scratching the surface of digital health coding? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.